Neurological problems, part 2. We're going to start with diagnostic tests that are done for neuro problems. And we're getting there. Sorry. Here we go. X-ray of the skull or spine, CT scan, MRI, magnetic resonance imaging, and that's all very basic. Cerebral angiography can also be done, where they inject a dye and look at the circulation. Your digital subtraction angiography will take out any distortions might be there. And then you've got magnetic resonance angiography that can be done, and interventional angiography. And we'll talk about some of those when we do our case studies. Myelography is where you inject a dye into the spinal column. You must do a lumbar puncture in order to do that also, but you can do a lumbar puncture in and of itself, by itself, to assess for meningitis, increased pressure, all sorts of different things. Your cerebral blood flow studies are assessed by the injection of a dye, a xenon dye, and then doing either a CT scan or a PET scan to see what they find. You can do a Doppler ultrasound and electroencephalogram. And this is showing what you're looking at for your spinal fluid analysis that you would do with your lumbar puncture. Then you need to keep your patient flat for 48 hours afterwards. You can elevate the head of the bed about 15 degrees if you have to, but you don't want to go much further than that because that'll cause cerebrospinal fluid to leak out, and then they'll get this lovely headache that just does not go away worth nothing. Neurological disorders, coma. Coma is a symptom with different stages. It's not a diagnosis in and of itself. Some of the causes are structural lesions such as vascular, tumor, abscess, or trauma, and metabolic and toxic conditions such as cardiopulmonary, poisoning, alcohol intoxication, hypertensive crisis, meningitis, encephalitis, post-convulsion, changes in blood sugar, uremic coma, and hepatic coma. Non-traumatic coma has a better prognosis than traumatic. And 30% of all comas are due to where coma is a symptom with different stages. You have your structural lesions, vascular, tumor, abscess, or trauma, and your metabolic and toxic conditions such as cardiopulmonary, poisoning, alcohol, hypertensive crisis, meningitis or encephalitis, following a convulsion, changes in your blood sugar, uremic coma, or hepatic coma. Non-traumatic coma has a much better prognosis than traumatic. 30% of all comas are due to overdoses of alcohol or drugs. And patients who do alcohol overdose, alcoholics, develop thiamine deficiencies over long term, and that causes causes the coma. And symptoms, what do you think? Most patients in coma respond to nothing external. Okay, so it's really difficult to assess if they're in pain or not. Researchers say they experience no pain. I don't necessarily agree with that because I see changes in respirations and blood pressure and heart rate that I think could be indicators of chest pain. So I will still medicate patients that are in coma. Maybe I'm just medicating my view of the symptoms, but I can support that with those symptoms, saying it's part of the stress response, and therefore they're uncomfortable. But they don't voluntarily move anything. They don't blink. They don't move. And because they don't blink or move, nursing care is total. They got to do it all. Eye care is really important because oftentimes the eyes will not shut all the way. They'll be partially open. And if they're open to the air, you're going to have drying, and ulceration is a risk for that. And so you need to make sure those eyes stay moist because, let's face it, they're not blinking. They're not stimulating their own tear ducts. So you need to do eye drops every 2 hours, cover them with a moist cotton ball. I like to use that because I have to check the pupils every couple hours anyway. There are ointments you can use that you only have to do once a shift. That gets really messy when you're trying to check the pupils. Eyelids get really slippery. A whole lot better just to use a little bit of saline to do that. But you got to keep the eyelids closed. And it's important when you have somebody in coma to include the family if they want to be. It's mandated if you do coma stimulation treatment that the family involved. But otherwise, it's really helpful to them because they're feeling helpless and powerless. And if you can get them to help you maybe with the bath or with turning or oral care, it makes them feel good about what they're doing. Coma stimulation treatment has been shown to decrease the time of coma and increase the recovery. But the patient must be medically stable and with a normal ICP before you start coma stimulation treatment. Taped voices of the family are best as long as they get along with their family. And you'll do these activities 2 to 4 times a day for 10 to 30 minutes at a time. You stop these activities anytime they have an increase in intracranial pressure, heart rate, respirations, blood pressure, or seizures. Now a little story. I took care of Stephen. Stephen was a 13-year-old who was playing around with a friend of his at his parents' home and found a gun underneath his parents' bed in a plastic bag. Not the best place to store guns, but what were the kids doing in his parents' bedroom under their mattress? Anyway, they took it out and started pointing it at each other and saying, "Bang, bang, you're dead." When the friend did it to him, he went, "Bang, bang, you're dead," and a bullet came out, lodged in the frontal lobe. Stephen proceeded to stagger to the front porch and fall down. The friend called the police and said somebody drove by and shot the kid. So Stephen was admitted to our hospital, our ICU. They were unable to take him to surgery and remove the bullet because if they did, they would have removed all of his functional frontal lobe. So he was on a ventilator in our acute care unit for almost 3 months. The mother would not give up. She was a single parent. The brother would come in and visit him all the time. And so we transferred him to our step-down unit because this was a self-pay situation and we were trying to make it a little bit better. Stephen had always wanted to be a football player. So his mother wrote to all the area football players, the Detroit Lions, the Cleveland Browns, the Pittsburgh Steelers, the Cincinnati Bengals, the Indianapolis Colts, told what was going on, and they all sent jerseys. They had pennants and things. So she decorated his room with jerseys and pennants, and she would talk to him all the time. And the doctors tried to get her to give up and say he's not going to get any better. And she said, yes, he is. So they decided to try some coma stimulation treatment. And they had him evaluated from an ECF in a rehab unit in Indianapolis. They said they didn't think they could help him. They had him evaluated from someplace in Michigan. They didn't think they could help him. And then Green Springs, Ohio came up and evaluated him and said, well, won't get any worse. So they took him to Green Springs. And 6 weeks after he was at Green Springs, he and his mother walked on to our unit. And he came up to the nurse's station, and I recognized the mother. I must admit, I did not recognize Stephen. And I went to ask how Stephen was, and she turned to me and said, "This is Stephen." And I said, "Well, hello, Stephen." And he said, "I recognize your voice. You took care of me." And I said, "Yes, I did." And he said, "I know." And he went through and he went the voices of people. So he recognized their voices. Hearing is the last sensation to go. And he understood who we were, and he thanked us all for his care, and he did quite well. So you cannot say that someone who's in coma will not get better. You really don't know. You treat them as though they will. A persistent vegetative state is where you have cerebral ischemia following cardiac arrest is the usual cause. With a persistent vegetative state, the eyes will open if you flex the elbow. They don't necessarily track objects or avoid threatening gestures. So if you were to take your hand and go to hit yourself in the nose, you blink. They would not. And they don't necessarily turn to the sound when they hear it because they're really not paying any attention to what's going on. Persistent vegetative state becomes permanent if more than 3 months in a non-traumatic state or more than 12 months after trauma occur. A persistent vegetative state was first defined in 1972, and it's defined as no awareness for more than or equal to 1 month. Sometimes they'll recover after 3 months. Usually, there's absolutely no recovery after 2 years. And some people in the literature are now calling this a minimally conscious state in some of the literature. They live on the average of 2 to 5 years. And before this occurs, you need to decide on treatment. You really, you guys should be making a decision now. What sort of things do you want to happen to you if you are in a coma, or if you become in a persistent vegetative state, or have an auto accident, or whatever? You should be making those decisions now. I'm tempted to have it tattooed on my chest when I reach a certain age, hands off, because I really don't think that resuscitation at certain ages is really beneficial to the patient. That's one of my medical biases, but we need to think about that. And you need to make that decision. As I said, some researchers feel you cannot feel pain. Now, there are 2 cases I have listed here. I have a couple other ones I've thought of. For example, there was the Florida case, the Tereshaivo. She was in a coma for over 7 years. She was taken to court because the husband had obtained a court order to remove her feeding tube that was sustaining her life, because she had been in a persistent state for 6 years. Since a non-traumatic injury, she had a cardiac arrest because of a major electrolyte imbalance. Her parents got the governor to order a stay while the appeals court studied the situation. This went all the way to our Congress and our Supreme Court. Eventually, they decided that the lower court order should stand, and the tube feeding was stopped, and she died. When they did the autopsy, they found that she was blind, so her eye movements meant absolutely nothing. It also showed marked cerebral atrophy, indicating that she would not have been aware of her surroundings and the people around her. Now, the policeman, on the other hand, had responded to a domestic violence call in one of the Carolinas. He was shot in the head and was in a persistent vegetative state for over 10 years. During that time, he had 2 sons before then, 6 and 8, and his wife divorced him and remarried. And he was at an ECF, and he was getting a bath, and while the caregiver was washing his back, he said to her, "Has my sister been in to see me?" She said, "Say what?" He said, "Has my sister been in to see me?" And she said, I'll go check. Well, she had. She'd been coming in to see him like 3 times a week, routinely, and talking to him. He was unaware of the 10 years that were missing, but he did remember some of the things he had been told. It worked out that he was paralyzed from the waist down. He knew he had been divorced. He knew his kids were older. He was able to meet them again, talk with them, spend some time with them. Unfortunately, about 6 weeks later, he was going into the hospital to have some testing done, and he threw a massive pulmonary embolism and died. But at least he came out of the coma and was able to talk to his children and his family. And that may have been part of the difference, in that his family was still involved in his care. There was a mechanic in Arkansas who had a motor vehicle crash, who was unaware for 18 years and awakened in 2003. And amazingly, he had no neurological deficit. There was a female in Kansas, another motor vehicle crash, who was unaware for 19 years. She's awake now and has no neurological deficit. And I was doing my clinical rotation in psych at what used to be the Toledo Mental Health Center. And I was taking care of Jimmy. And Jimmy had been in a persistent vegetative state, not moving anything or paying attention to anybody for 18 years. He had been hit by a train, and his son had been killed at that time. And so he was basically unresponsive. And it was my task to change his dressings on his hand. and he was he was kind of contractured up, and he wasn't moving voluntarily on his own. So he had carbuncles on his hand, and I was dressing those. That was my task for that day, was to do all the treatments. And so I went in to change his dressing. And I talked to everybody. I mean, I talked to my patients in coma all the time. So I was talking to him and telling him basically what was going on that day, and what the weekend had been like or whatever. And he reaches up with his hand with these long fingernails that had never been cut, I don't think. Well, at least it didn't seem like it. And came down and scratched my neck and grabbed hold of the front of my uniform and pulled me down to where I was like within 1.5 inches of his nose. And I'm saying to myself, oh my God, what do I do now? So I said, oh, that's nice. Just hold your hand like that. And I continued to dress his hand and tell him what I was doing. And he relaxed his hand. And as soon as I finished the dressing, he put his hand down, and I got out of that room. And I went out and I said, you told me he wouldn't move. Well, he doesn't. I said, look at my neck. I had to get another tetanus shot. I wasn't thrilled. So you cannot assume your patients will not move or do things. Brain death before you can determine this, the patient must be warm and without any drugs in their system. Otherwise, you cannot determine brain death at all. You need to make sure that you have determined that. Stroke. It's the third leading cause of death in the United States. It costs, let's see, it costs, no, it doesn't cost. It's 795,000 Americans suffer strokes each year. 144,000 deaths from that each year, but that is down about 30%. But every 3 to 4 minutes, someone dies from a stroke. And by the time you're 85, that risk for stroke doubles. It costs $41 billion a year to treat somebody who has a stroke. 29% are recurrent, 80% are due to ischemia, and 67 to 85% of the patients will survive for at least 30 days. And some well-known stroke survivors are President Gerald Ford, Teddy Bruschi, Charles Schultz, Sharon Stone, Harry Carey, Della Reese, Charles Dickens, Kirk Douglas, Ed Koch, who was the mayor of New York City, Ted Williams, the baseball player, and Roy Horn of Siegfried and Roy are all possible. 30% of strokes are due to blood clots, atrial fibrillation, or acute MI, which puts you at greater risk for a blood clot, or elevated C-reactive protein, which is your inflammatory marker. It can also be due to use of contraceptives and a family history, hypertension, diabetes, coronary artery disease, smoking, and hyperlipidemia. And here we have a diagram from the memory book that's showing stroke, whether they're reversible, partially reversible, not reversible, risk factors, nursing goals, pupillary abnormalities. So the pathophysiology of a stroke. Warning might be a TIA. Now, TIA is a transient ischemic attack. There is no residual and the symptoms last less than 24 hours. And RIND, on the other hand, is a reversible ischemic neurological deficit or attack. This lasts at least 24 hours to several weeks, but again, there is no permanent deficit afterwards. RINDs tend to occur more often with atherosclerosis. If it's sudden, it's due to an embolism. Global ischemia will occur after a cardiac arrest or a hypotensive episode, and that can get better. Cerebral edema will peak 3 to 5 days after the injury, and that means they'll start to get better after that. Complications are seizures and secondary hemorrhage. Symptoms depend upon the area involved. Initially, there will be a change in your level of consciousness, and that occurs with involvement of your brainstem or cerebellum involvement, or an increase in intracranial pressure, hypoxia, hemorrhage, and seizure. If a seizure, that will occur within the 24 hours. Now, from the memory book, here are some symptoms of a right-sided or of a stroke, just generalized. This one is a left CVA. I have some trouble thinking. What do I eat with a spoon? And a right CVA, where they don't really know where their left side is. Subarachnoid hemorrhage, 25% mortality rate. Females more than males. Risk factors: smoking, hypertension, smoking and alcohol together, and an increase in stimulant use. 75% are due to a cerebral aneurysm. Average age, 50 to 60. It's usually saccular in nature, located in the circle of Willis at the base of the brain. It can cause pressure on the optic nerve, which will result in ptosis, which is drooping of the eyelid, and ipsilateral pupillary dilatation, which means on the same side as the aneurysm, the pupil will dilate, and it will become fixed if it's not taken care of. 10% are due to AV malformations, arteriovenous malformations. That average age is between 20 and 40. Symptoms: headache, change in level of consciousness, nausea, vomiting, nuchal rigidity or a stiff neck. Intracerebral hemorrhage destroys your cerebral tissue. Usual cause is hypertension, AV malformation, aneurysm, tumor, coagulopathy. Mortality: 35 to 50% within the first month, 50% within the first 48 hours. Tends to be more men, more non-whites. Symptoms are due to that increase in intracranial pressure, change in your level of consciousness, hypertension, blood pressures of 250 over 150. This is diagnosed by using a CT scan. Nursing care. You need to assess them continuously for an increase in intracranial pressure, for bleeding, vasospasm, pneumonia, deep vein thrombosis, or pulmonary embolism. Symptoms of a bleed: hypertension, headache, nausea, vomiting, change in respirations. Symptoms of increased intracranial pressure: change in level of consciousness, unequal pupils, headache, projectile vomiting, Cushing's triad, again late symptom, not good, posturing, and a change in respirations. Vasospasm symptoms will be a new neurological changes, and you can prevent that by controlling the blood pressure, putting your patient on bed rest, keeping the room dark and quiet, giving them stool softeners, and elevating the head of the bed about 30 degrees. And from the memory book, we have a design of increased intracranial pressure so you can see the symptoms. And then signs and symptoms of worsening increased intracranial pressure, which is your Cushing's triad that occurs. If you have damage to the non-dominant hemisphere, you'll have emotional lability. That means you'll laugh really easy and then you cry, and you may be doing that to a joke, or you're laughing and crying, or you may be doing it to the news that somebody you cared for died. You just really don't have any control over your emotions. Short attention span, poor judgment and insight, agnosia, which is a change in your spatial orientation, or change in perception, can cause universal neglect where you ignore one whole side of your body. Apraxia is the inability to perform a learned movement voluntarily. And you may have visual field problems, where you only see half of a field in each eye. Damage to the dominant hemisphere, you'll have a problem with speech and language. You'll have both receptive and expressive aphasia, or global aphasia. Wernicke's area is involved, you'll have receptive aphasia, so you hear gobbledygook. With Broca's area, you'll speak gobbledygook. And with global aphasia, both areas are involved, and you cannot communicate in any way, shape, or form because you don't hear what people are saying and they don't understand what you're trying to say. Hematoma is an increased intracranial pressure, causes increased intracranial pressure. An epidural hematoma is above the dura. It causes a tear of the middle meningeal artery due to low impact injury or high impact injury. Low impact injury is like a fall. High impact injury is like a motor vehicle crash. Symptoms are a brief loss of consciousness to lucidity, so you're awake and aware, and then loss of consciousness later. You'll have ipsilateral pupillary dilatation that becomes fixed and dilated. You'll complain of a headache, feeling sleepy. You all know Natasha Richardson, Liam Neeson's wife, who died in, I think, March from a skiing accident. She had an epidural bleed. This was diagnosed with CT and was unable to be treated with surgery because it was too long. I think they ended up donating most of her organs. Subdural hematoma means it occurs below the dura. You could have a contra-coup injury, which we've talked about, due to acceleration, deceleration, and rotational forces. There are three types. You have your acute, which requires immediate surgery, your subacute, which occurs over 2 to 14 days after the injury, and your chronic, which develops over days to months later. With the chronic, the symptoms are very vague, kind of insidious. They sneak up on you before you realize they're there. Recurrence is frequent and tends to occur mainly with the elderly and or alcoholics. An intracerebral bleed is due to a depressed skull fracture, penetration, or rapid acceleration, deceleration, and rotational forces. Symptoms are those of increased intracranial pressure, and they may or may not require surgery. They're kind of cautious about surgery because they would have to destroy so much brain tissue on the way to get there. This finishes part 2, and we'll start part 3 in just a few minutes.